Immunity presenting with invasive fungal infections as a single center experience from the Pediatric Allergy and Immunology and Rheumatology Unit of a Children's Hospital and Shams University, Cairo, Egypt. No conflicts of interest. An effective host response against fungal pathogens requires coordinated contribution of both innate and adaptive immunity. Invasive fungal infections constitute a major cause of morbidity and mortality in the immunocompromised host. And we herein describe fungal infections encountered in a group of patients with inborn errors of immunity. Our patients, among 680 patients with inborn errors of immunity, 42 had documented invasive fungal infections, and they were 26 boys and 16 girls with age ranging between 4 months and 13 years. Concerning the underlying immunodeficiency, 40% of the patients had phagocytic disorders. Among those 17 patients, 15 had chronic granulomatous disease, and 24% of the patients had severe combined or combined immunodeficiency. 12% of the patients had underlying immunodysregulation disorders, and 5% of the patients had intrinsic or innate immune defects. Only 2% had predominantly antibody deficiency, while 17% had unclassified or undiagnosed immunodeficiency. Concerning the organs affected by the fungal infections, 52% had mucocutaneous infections, 45% had pulmonary infections, pulmonary aspergillosis, and 19% had bone and joint fungal infections, 17% had intracranial infection with fungi, 10% had hepatic lesions, fungal lesions, and the eye and the intracardiac were the least affected. Aspergillus and Candida species were equally prevalent among the described cases. Each of them was found and documented in 21 patients, followed by pneumocystis jirovecii, and then mucormycosis and exophiala dermatitis in one patient. And here I'm going to show you some of the clinical presentations in our patients. In this one, this girl had a chronic granulomatous disorder with cutaneous fungal granuloma that responded after that to voriconazole. And this is another 2 patients with chronic granulomatous disorder having pulmonary aspergillosis. And this another patient with CGD having a hepatic aspergillus lesion that necessitated surgical intervention due to causing biliary obstruction. And another patient with CGD having, as pointed by the arrow on the left lesion, there was osteomyelitis, fungal osteomyelitis that ended up in a bony defect, as we can see on the picture on the right side. Another patient with a card9 defect has cutaneous abscesses with exophiala dermatitis, as shown here in the pictures. And the aspiration of the fungal abscesses revealed the growth of the exophiala dermatitis, as shown on the right side. And here we can see the same patient developing osteomyelitis with significant bony defects, in addition to intracranial lesions that was the cause of the death of this patient. Concerning the antifungal therapy received, amphotericin B was received in around 24 patients among the 42, and voriconazole was received by 31 patients, and posaconazole received by 21.4%, fluconazole in 21.4%, and anidulafungin was limited in availability, so used in 2 patients only, while combined antifungal therapy was required in around 14 patients. However, there was a significant failure in the antifungal therapy in some of our patients. Amphotericin failed in 33%, voriconazole in 35%, posaconazole in 33%, fluconazole in 55%, and anidulafungin failed in 1 of the 2 patients who received it, and combined antifungal therapy also failed in 35% of our patients, and thus we had a significant mortality rate among the patients, reaching 23 out of 42 patients, which is 54%. We have met several challenges in managing cases with invasive fungal infections, including the delayed diagnosis. There was a significant diagnostic lag before the diagnosis of underlying immune deficiency and diagnosing the presence of fungal infection. So fungal infection disseminated before we can proceed to the hematopoietic stem cell transplantation. the time-consuming fungal culture, the lack of diagnostic laboratory test, and the non-specific radiological feature in several times, 2 large fungal masses that necessitated debulking in our patients, which was needed in 2 of our patients, and difficult to reach fungal infection like those with intracardiac or eyes or bones and brain. Also, there are several factors that are related to the antifungal drugs, including the limited availability, sometimes resulting in interrupted courses of treatment, and the expensive cost for prolonged therapy, whether in the parenteral form or in the oral form, many drug interaction, especially among chronic granulomatous or severe combined immunodeficiency patients who usually require to receive the antituberculous treatment together with the antifungal, and the drug interactions might hinder this combination, and the drug side effects, especially hepatotoxicity, was a common problem in our patients. Finally, I would like to deeply thank Professor Raif Jiha and his team in Boston for helping us in the genetic diagnosis of our patients and the interpretation of their data. And also, I'd like to thank Professor Casanova and his team for helping us in the diagnosis of some patients. My deep acknowledgement to the Pediatric Allergy, Immunology, and Rheumatology Unit founded by Professor Yahya Al-Gamal and helped by all other professors and colleagues. And thanks to all of them. Thank you.